Thank you so much for the invitation to speak today on liver tumors. My name is AeRang Kim, and I am a pediatric oncologist at Children's National Hospital in Washington, D.C., and I have no disclosures. The interesting thing about pediatric liver tumors is that 2/3 of all liver tumors in children are actually malignant, which account for about 1.1% of all pediatric malignancies, roughly about 100 to 150 new cases in the U.S. per year, so quite a rare disease. Two of the most common liver cancers are hepatoblastoma, where 90% of cases actually occur before 5 years of age, so really a disease of the young, versus hepatocellular carcinoma, where the majority of liver cancers occur in late adolescence. So much so they can actually think about liver tumors by age group, including the benign liver tumors, where the majority of young are vascular malformations, where the older kids are adenomas or focal nodular hyperplasia. Where in the malignant tumors, we really do think a lot about hepatoblastoma as the most common pediatric liver tumors and accounts for 80% of all of the malignant liver tumors in childhood. And again, really a disease of the young. But still, we think about rhabdoid tumors and germ cell tumors in this population. When we think about middle childhood, things like rhabdomyosarcoma and embryonal sarcoma come to mind. And really in adolescence, hepatocellular carcinoma are highest in our differential. For the rest of the talk, I'll really be focusing on hepatoblastoma and hepatocellular carcinoma, as these are the most common cancers that we see. There are predisposition factors that increase one's risk for hepatoblastoma, including some genetic, such as Beckwith-Wiedemann syndrome, which is a congenital growth disorder in the growth regulatory genes on chromosome 11p15, which increases one's risk for hepatoblastoma by 2,000-fold. And familial adenomatous polyposis, or FAP, which occurs from a mutation of the APC gene, which encodes for a tumor suppressor protein that acts as an antagonist on the Wnt signaling pathway. This is actually interesting because activation of the Wnt pathway or mutation of the beta-catenin gene are actually seen in greater than 90% of all hepatoblastoma cases. And this FAP has an 800-fold increase for hepatoblastoma. So in these genetic predisposition, active surveillance with alpha-fetoprotein and ultrasounds are indicated if they have these predisposition factors. Interesting, environmental factors also increase risk for hepatoblastoma, including low birth weight. And there's an increased incidence of low birth weight in premature infants, and this seems to be increased with decreased weight, with the relative risk being greater in babies under 1,000 grams. The most common clinical presentation for these tumors are a painless, palpable abdominal mass. Sometimes weight loss, anorexia, and constipation, abdominal pain can occur, but this is particularly in the advanced setting. Usually, your LFTs are normal and there's no jaundice, and if we do see jaundice, biliary rhabdomyosarcoma should be on our differential. Thrombocytosis is common as hepatoblastomas tumors secrete thrombopoietin, and sometimes we can present with precocious puberty, but that's quite rare and commonly seen in our germ cell tumors that have beta-HCG-eluting tumors. The evaluation for this disease should include diagnostic imaging, including ultrasound and Doppler, to evaluate for cystic versus solid masses, patency and involvement of the vascular system. In addition, a CT scan of the chest, abdomen, pelvis, and an MRI of the abdomen should also be performed. The lungs are the most common site for distant metastases, occurring about 20% of all patients, and looking for extent of disease, including intraperitoneal, lymph node, local tumor thrombosis, and extent of disease. Laboratory workup is also important, as AFP is an important tumor marker in this disease, and also looking at some other rare differential diagnoses, such as a germ cell tumor with beta-HCG. And of course, a biopsy is required ultimately for pathology diagnosis. So liver tumors are lucky in that they have an excellent tumor marker called alpha-fetoprotein, which is elevated in about 90% of all hepatoblastoma and 60 to 70% of hepatocellular carcinoma. It's actually normal in the fibrolamellar variant of HCC, and it can be mildly elevated in infantile hemangioendothelioma and mesenchymal hamartoma. We do have to have some caution because AFP can be actually normally elevated in normal term infants as well as premature infants. And there are some normative values in the literature, but these should not be continuing to rise, but actually decrease over time if there is no liver tumor present. The half-life of AFP is about 7 days, and a low AFP of less than 100 nanograms per ml is actually associated with worse prognosis in hepatoblastoma. There is a staging system that has been used both in the European and North American group. The Europeans have been based on the pretext, which is preoperative chemo or pre-treatment extent of disease, where North America has traditionally been used on surgical resectability and presence of mets. And I'll talk a little bit more about how we've come together in determining staging and using this as risk factors, determine risk categories for liver tumors. So pretext, which is the pre-treatment extent of disease, is quite easy to follow. Basically, in pretext 1, there's only one quadrant involved, meaning that 3 adjoining sides are free. In pretext 2, 2 adjoining sides are free. In pretext 3, 1 sector is free, and in pretext 4, there are no free sectors. There are also annotation factors that are important, including the presence in the vena cava or the main portal or portal bifurcation, whether there is continuous extrahepatic tumors, multifocal tumors, rupture prior to diagnosis, involvement of the caudate lobe, enlarged lymph nodes, or distant metastases. And these will also play into the staging system. For treatment of these hepatoblastomas, we know that surgery or resection is key to cure, but only 1/3 of these patients have resectable disease at presentation. So how to get them resectable is very important. We know that hepatoblastomas are very chemosensitive tumors and primarily have been treated using cisplatin-based chemotherapy, with the C5V regimen occurring in North America and Plato, which is cisplatin doxorubicin, occurring in most European centers. Most chemotherapy response occurs within the first few cycles, and risk-adapted therapy have been used based on stage and pathology. So pediatric liver tumors really is a great example of how we can work together to come up with better methods to treat our rare cancers. So the Childhood Hepatic International Collaboration is a mega cooperative group, including members from COG, SIOPEL, the Japanese liver tumors, and the German group, forming together to come up with a consensus in terms of the risk groups based on major prognostic factors, including pretext stage, the presence or absence of metastases, age greater than or equal to 8, and AFP less than 100. And they've been able to categorize these into very low, low, intermediate, or high risk groups that ultimately can be used for the treatment protocol. And the Pediatric Hepatic Malignancy International Therapeutic Trial, or FIT, was developed again through this super cooperative group, which will ask very important questions in this very rare tumor type. So 1, can we reduce cisplatin exposure in non-metastatic hepatoblastoma and eliminate doxorubicin, which is a chemotherapy with significant late effects? Can we integrate additional agents for metastatic hepatoblastoma that have poorer survival rates? Can we evaluate the benefit of chemotherapy in pediatric hepatocellular carcinoma? And can we use this common international risk stratification integrating CHIC for hepatoblastoma into 4 risk categories? So these are the risk groups for the FIT study. So we have a very low risk group, which we know has a pretty good outcome, greater than 90% event-free survival. And this is a patient population that may be able to avoid chemotherapy altogether. So we believe in the well-differentiated histology that are completely resected may be cured by surgery alone. But those that don't have the well-differentiated histology, previously known as pure fetal histology, may be okay with just 2 cycles of cisplatin. The low-risk category, which also have a great outcomes of greater than 90%, are those with low pretext stages without any positive annotation factors, and those can be treated with adjuvant chemotherapy. And the The biggest group, which is the intermediate group, which has a range in terms of outcomes, looks at pretext 1 to 3 with positive annotation factors. And here we're randomizing the North American regimen C5VD versus cisplatin in an interval compressed regimen to determine if there's a difference in the treatments that are used across the pond. And in our high-risk group, the ones with the worst survival and outcomes, the metastatic or the age greater than 8 or the AFP less than 100, we're looking at additional chemotherapeutic regimens to see if there is improved response. Again, we know that surgery is key in hepatoblastoma, and sometimes liver transplant is the only way for that complete resection. And this occurs in about 10% of our patients. Patients who undergo liver transplant have improved survival if they have a good response to chemotherapy, and if we can complete the response as soon as possible to avoid excess pre-transplant chemotherapy. Lung metastases is not a contraindication of hepatoblastoma, in particular if they can be resected. And a key finding is that early referral to liver transplant is important. So if we think that a patient is going to require a transplant in the future, they should be referred as early as possible to a transplant center. Now I'm going to move over to hepatocellular carcinoma, which is, again, a liver cancer that we see particularly in the adolescent and young adult groups. The interesting thing about pediatric hepatocellular carcinoma is that most of them are de novo, meaning that that's quite different from adults that typically develop in a setting of cirrhotic livers or chronic liver disease. In children, this is quite rare. Children with underlying liver disease, such as tyrosinemia or glycogen storage disorders or other types of environmental hepatitis, do have an increased risk of developing HCC, but most of our pediatric cases are de novo. There's a high percentage of fibrolamellar variant, which is about a quarter of all the hepatocellular carcinomas seen. And in this, the AFP is actually quite low, and the majority of the fibrolamellar variant. Most of the hepatocellular carcinoma presents in an advanced stage, which is important because we know that surgery is, just like hepatoblastoma, is in particularly key for hepatocellular carcinoma, which makes it harder when it is presenting in an advanced stage. The response to chemotherapy is a little bit more poor than in hepatoblastoma, with probably less than about 50% actually responding to chemotherapy. And other methods to shrink the tumor have also been used, including cryoablation, radiofrequency ablation, and chemoembolization, again, to try to get to surgery and or resection. So the International FIT study does have a hepatocellular cohort under evaluation, and the primary objectives are to determine event-free survival in hepatocellular carcinoma that is completely resected at diagnosis. And those with de novo HCC, we would recommend adjuvant chemotherapy such as cisplatin doxorubicin. Those with unresectable or metastatic hepatocellular carcinoma at diagnosis, which typically have a very dismal prognosis, we work in terms of early transplant and interventional consultation, and we're looking at the backbone of cisplatin, doxorubicin, and sorafenib, which is a tyrosine kinase inhibitor, versus the backbone with GemOx, and whether that would improve chemo response or not. We know that the outcomes for localized or fully resected or post-transplant, those that we can get rid of, have an excellent survival of almost 75% 5-year survival, but those with metastatic or advanced disease have a very poor survival with 10 to 23% 5-year survival. All these therapies come with a significant amount of late effects. We know that cisplatin, which is the basis of all the chemotherapies for hepatoblastoma, hepatocellular carcinoma, is associated with hearing loss. There are some preventative methods that we can use that may augment the hearing loss, including sodium thiosulfate, where administration post-chemotherapy decreasing hearing loss by almost about 50% without compromising survival. We also know that cisplatin can have a significant amount of renal toxicity, that anthracyclines can have a significant amount of cardiotoxicity. There's a potential to develop secondary malignancies, and there's always a post-operative complications from liver resection and from liver transplant. So the costs of cure are not minimal. And we also know that patients with advanced and metastatic disease for both hepatoblastoma and hepatocellular carcinoma have very poor outcomes. So obviously there is a great need for novel therapies and new treatments. And these are novel therapies that we think beyond tyrosine kinase inhibitors such as sorafenib. We know, as we mentioned, that greater than 90% of hepatoblastomas have a mutation in the beta-catenin pathway, and that the beta-catenin pathway activation is important in the development and the pathogenesis of liver tumors. Tegavivint is a small molecule that interferes with beta-catenin binding to TBL1 and may have a role for treating liver tumors. This is currently under investigation in a phase 1-2 setting, and more information to be seen. Glypican-3 is a surface protein that's on liver tumors, and agents targeting Glypican-3 are being evaluated, in particular a Glypican-3 specific CAR T cell, as well as GPC3 monoclonal antibodies, and these are also under investigation. For some tumors, interventional therapies such as embolization, cryoablation are important also in order to treat metastatic sites as well as potentiate ability for surgery or transplant. And one of the things that are evaluating are transarterial radioembolization with yttrium-90. And then the more we learn about these tumors in terms of their genomic pathways, potential mutations, we can learn about potential future targets for this disease. So in conclusion, I think we can say that effective chemotherapy regimens and advanced surgical techniques really have improved the outcome for pediatric liver tumors. And advances in pediatric liver tumors really demonstrate the power of cooperative groups. This is a rare disease, and with the power of cooperation, we've come and made a lot of strides. We have 4 very large cooperative groups working together as one to develop the CHIC global risk stratification, which ultimately led to the FIT therapy trial. And ongoing research in the biology, molecular, and genomics of liver tumors will lead to continued improvements in the diagnosis, staging, response to treatment, and novel therapies. Thank you so much for your time.